To present Dr. Lozano, I will ask the presence of our chief of the Department of Neurosurgery at the Hospital de Clínicas, Dr. Apio Antunes. Please.
Bom dia a todos. I'll speak a few words after to Professor Lozano, mas é um grande prazer ter o professor André Lozano aqui. O professor Lozano é chefe de neurocirurgia da Universidade de Toronto. É um dos maiores especialistas no mundo em cirurgia funcional. E para aqueles mais jovens que não conhecem, cirurgia funcional é todo tipo de cirurgia que, de alguma maneira, modifica circuitos cerebrais. Os grandes exemplos são a cirurgia do Parkinson, a cirurgia da epilepsia, e hoje em dia, mais modernamente, algumas cirurgias que estão se desenvolvendo, que é a cirurgia da modulação do humor e a cirurgia da doença de Alzheimer. So, Professor Lozano, it's a very great pleasure to have you here. We know each other for a long time, but this institution is very proud to have you here. Please come along.
Well, thank you so much. It's such a pleasure to be here, and thank you, Dr. Apio Antunes, for the kind invitation. It's my first time in Porto Alegre, and I'm enjoying my visit to Brazil very much, so thank you very much for the kind invitation. I am interested in understanding how the brain works, and I'm interested in being able to go within any circuit in the brain and adjusting its activity, either to turn it up or down, like adjusting the volume in a radio. So what I'm going to be telling you about today is the possibility of going anywhere in the brain and adjusting the activity of circuits that are dysfunctional. When the circuits are underperforming, we are able to activate these circuits and to increase their function and activity. When the circuits are overperforming and generating an error signal, we are able to suppress the activity in these circuits. So this is what we will be discussing today, is traveling throughout the brain, placing electrodes in the brain to then be able to deliver electricity focally and change the activity of these circuits in the brain. And one of the principles that I'm going to tell you is that, to me, there is no distinction between neurology and psychiatry. These are brain disorders. When a disorder affects a circuit that controls movement, we call it neurology. We call it Parkinson's disease. When it is a disorder that affects a circuit that controls your mood and causes depression, for example, we call it psychiatry. But the principles are the same. We are dealing with focal dysfunctions within groups of neurons. These neurons are connected and speak to other areas of the brain, and together we have the dysfunction in a very small number of neurons that cause widespread dysfunction within a circuit, and the readout, the outcome of that, is a neurologic or a psychiatric disorder. The readout is dependent on which circuit is affected. And so when you have a motor circuit that is dysfunctional, you get Parkinson's. When you have a memory circuit, you get Alzheimer's. When you have a circuit that controls your mood, you have depression. And so the fundamental principle is that we have dysfunction within circuits. These create a network dysfunction, and then we have a readout that produces the signs and symptoms that we know as neurologic and psychiatric illness. So again, we are going to intervene within these circuits. We're going to pinpoint where these disturbances are within these circuits. Then we're going to intervene to adjust the activity within these circuits to see if we can influence the behavior that our patients experience. And this is done using this material. This is a deep brain stimulator. And so we are able to place these electrodes anywhere in the brain. I tell my neurology and psychiatry friends that no neuron is safe from a neurosurgeon. We can go anywhere in the brain, in the brainstem, in the cortex, in the basal ganglia. We can place these electrodes anywhere. We can then hook up these electrodes with a cable like this to a pacemaker, and then through the skin, very much as you would adjust the volume on your television, we can turn the volume up and down to deliver more or less electricity within these targets in the brain. This is the area of neurosurgery that has the fastest growth. If one counts the number of papers that is published in the field of deep brain stimulation and plots them as a function of time, you'll see that in the 1980s there were about 20 papers, and last year, in 2013, there were over 800 papers. And so this rate of exponential growth is the highest in all of neurosurgery. There's nothing else in neurosurgery that is growing at such a fast rate. About 100,000 patients in the world have now received deep brain stimulation to treat Parkinson's disease. And with the realization of the efficacy and safety of deep brain stimulation to treat Parkinson's disease, we are now considering applying the same principles to other circuits in the brain to treat other disorders. And I've recently compiled a list of disorders that are being investigated with deep brain stimulation. So we published this last year. What we did was we went to the nih.gov site, and there are 93 new phase 1 clinical trials of deep brain stimulation. And if you look at what disorders are being investigated for their potential treatment with DBS, you'll see that there's Parkinson's disease, depression, obsessive compulsive disorder, Alzheimer's, dystonia, epilepsy, drug addiction, headache, tremor, anorexia nervosa, bipolar disorder, chronic pain, diffuse Lewy body disease, Huntington's, Tourette's, traumatic brain injury. It may be possible to, for example, wake people up from coma by activating the reticular activating system. It may be possible also to treat obesity. It might be possible to downregulate the hypothalamus, to downregulate appetite centers in the hypothalamus, and so doing treating obesity, tremor, urinary dysfunction, and so on. So you'll see that almost every neurologic and psychiatric illness is being considered as a potential target for deep brain stimulation surgery. Now, I told you that the principle of deep brain stimulation is that we are identifying neurons that are misbehaving and we are trying to change their activity. And here's one such example. What I'm showing you here is the tracing from one neuron in the subthalamic nucleus. The subthalamic nucleus is a motor nucleus in humans. It has about 400,000 neurons. So this is one neuron. And here is a neuron firing under normal conditions. But this is the same neuron that now changes to a pathological pattern of firing. And what you'll notice is that instead of firing in this irregular pattern, now the neuron is firing in clusters of action potentials like this. And these occur every 200 milliseconds. That means that 5 times per second, bang, 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 the neuron is firing this cluster of action potentials. And this neuron is causing tremor. Bang, 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 bang. Every time that it is firing in this oscillatory pattern, you get a beat of tremor. And this neuron can change spontaneously from a non-oscillatory pattern to an oscillatory pattern. It can go back and forth like this hundreds of times a day. And this is why patients have tremor part of the day, not other days. And when they have tremors, 5 minutes later, they don't have tremor. It comes back 5 minutes later, and so on, because the neurons are shifting from an oscillatory to a non-oscillatory state. And so we are able to localize these neurons, and we can say, gentlemen, that's enough. We don't want you to fire like that anymore. And there are two ways that we can do that. One is we can destroy these neurons. We can make a lesion and destroy them. And when you destroy these neurons, then they no longer fire in this abnormal pattern. Or we can put an electrode in their vicinity and use electricity to stimulate them and block this pathological behavior. So this is the principle. We find these misbehaving neurons and we tell them to stop with electricity. And in this case, I'm showing you an example in Parkinson's disease, but I can show you similar examples in other things, like in depression, like in epilepsy, where you have neurons that are misbehaving or misfiring. And if you find them, you can then place an electrode in their midst and use electricity to stop that. And when you do stop that, then the system can perform in a more normal fashion. So by way of example, here's one patient with Parkinson's disease, and this is a lady who's about 50. And she has these electrodes in her subthalamic nucleus, and she has the pacemaker in place already. And I'm going to show you what she's like with the pacemaker off and then on.
Should you try touching my finger? That side's a little better.
That side is better, yeah.
Very good. Just turned it on.
So this works instantly. As soon as we turn it on, the neurons stop oscillating, the tremor goes away. The reason I'm showing this is because I was a young boy when this film was done. This was 20 years ago. This lady now, even though it's been 20 years, she's now on her 5th battery. Every 5 years we change her battery. The batteries last about 5 years. But even today, after 20 years of stimulation, 24 hours a day, 1,000 impulses, 1 billion impulses, okay, 130 times a second for 20 years. Even today, after 20 years, after I turn off the stimulator, the tremor comes back immediately. And as soon as I turn it on, it goes away immediately. So these neurons are very tough. They keep their bad habits for 20 years, you know, and so just to give you an example. So the reason that she has the tremor is because 25 neurons in her subthalamic nucleus, 25,000 neurons are firing at this oscillatory pattern. And as soon as that stops, the tremor goes away. So that is the principle, is finding these troublemaking neurons and then telling them to stop. Now, you can also apply this to other things, and where else are we interested in finding troublemaking neurons? Well, in one case, what we're interested in is in pain, patients with chronic pain. So where in the brain do you feel pain? So you can do an experiment, and you can apply a painful stimulus, and you can do fMRI, and you can see what areas of the brain become activated during pain. And so this is what this experiment is. And so we apply a laser to the skin, we heat the skin, and then we see that, for example, the insula becomes activated, the anterior cingulate gyrus becomes activated, S1 and S2, the primary and secondary somatosensory cortex. So when you see this thing light up in the MRI, what does that mean? Is that for real? How do you know that that's for real? What about if it's just artifact? What if it's just garbage? Well, one of the things that we can do is we can say, well, maybe these areas are involved in pain. So we can put an electrode in and we can measure the neurons in this area of the brain to see how they respond to pain. So this is what we can do. So we can, for example, here we are measuring the activity of a single neuron in the cingulate gyrus, for example, this neuron over here, and we are applying a temperature increase in the skin. So 44, 46, and then measuring the neuronal activity. So at 44, the neuron is firing at a low rate, 46 at a low rate, but now we go to 48 degrees, and indeed the neuron starts firing at a very high rate, you see here, and then at 50 degrees here. So what we know then is that these neurons that are lighting up with the fMRI, they are real, because what we see is that when we increase the temperature, these neurons are increasing the activity, and this then is giving rise to the signal that we see in the fMRI. So we can validate the fMRI by going directly and obtaining direct measures of cellular activity in these individual neurons. So this means then that we can use imaging to localize new targets. When we have a patient with pain, when we have a patient with schizophrenia, when we have a patient with depression, we can see what areas of the brain are active or hyperactive. And that is a potential target for us to intervene with an electrode. And this is how we discover new brain targets for neurologic and psychiatric disease. We use imaging to see what areas are involved in the illness, and then that is the hypothesis that intervening at that level will have an effect, a clinical effect. So this is how we generate the new targets in functional neurosurgery. Another thing that we're interested in is epilepsy. And here we have overactivity in certain neurons. And as you know, you can resect epileptic foci in patients who are medically resistant to pharmacotherapy. But there are some patients that have multifocal epilepsy or where we cannot find the focus. And there we try to change the excitability between the thalamus and the cortex. So we place electrodes in the thalamus to change cortical excitability. And this is done something like this. So here we have a patient, for example, that had a corpus callosotomy, who had generalized seizures, and then she continued having seizures, and then we placed electrodes in the thalamus, in the anterior nucleus of the thalamus, shown here. So here's the right and left electrodes. And through these electrodes, you can stimulate, and you can also record. So in this particular example, we have the thalamic electrodes here, and this is a patient with epilepsy who goes on to have a generalized seizure, which starts over here. But the important thing here is that for many seconds before the seizure starts, 1, 2, 3, 4, 5 seconds before, you see a sharp spike and wave. So this is a warning. You have a 5-second warning that there's going to be a seizure in 5 seconds. And that means that you have a 5-second window of intervention to strike, to do a preemptive strike. So you're able to detect a seizure coming, and you're able to stimulate, and hopefully you can prevent the onset of a generalized seizure. So this would be an example of a stimulation system that is not on constantly, but rather is on a contingency basis, where you identify an abnormality and the stimulator turns on only when the abnormality is detected. And this is an example of a closed loop system. So this is actually done by a company called NeuroPace, and they place these electrodes in the brain, and this is the monitor that goes on the skull. You dig out a trough. You dig a trough in the skull, you place this on the skull, and then you're able to continuously monitor the EEG activity, and when you detect a seizure coming, then the stimulator kicks in. And this is now approved by the FDA just recently in the United States. Another example is depression. We discovered that there are patients, of course, with depression, which is a very common disorder. They take many drugs. There are 30 different kinds of antidepressant drugs. There's also a psychiatric therapy. There's even electroconvulsive therapy. But somewhere between 10 and 20% of patients fail all of that and still are severely depressed. So we wanted to operate on them. And the issue is, where in the brain can you go to treat depression? So we used imaging. And what we discovered is that, in contrast to normal individuals, patients with depression have hyperactivity in this area of the brain, area 25. So this is a resting blood flow scan, and compared to normals, there's hyperactivity, increased blood flow in area 25. It turns out that area 25 is the sadness center of the brain. If I tell you that Brazil just lost the World Cup, everyone, area 25 would go up in the room, okay? Because it's the sadness area of the brain. The patients with depression, they have this sadness area on the brain on overdrive, very high, constantly on. They are not able to turn it off. It is on all the time. So we thought, why not go to this area of the brain, put electrodes in, and see if we can turn it down, turn down the activity. So that's what we did. We placed electrodes in this area of the brain, and sure enough, 60% of the patients, we were able to improve their depression. These were patients who had tried everything, had failed everything. And we were able to show that this is before the operation, this is after. The blue areas are the areas that go down. By turning on the stimulator in area 25, we were able to turn down the activity, going from red to blue at 3 months and at 6 months. So we were able to turn down this area of the brain. The sadness area, we were able to turn down, and the patients got better. So here's an example again where we used imaging to identify a new target. And this is currently in phase 3 clinical trials to see whether this could be safe and effective to become a new therapy to treat patients with depression. One of the things that we noticed is no one had ever been to this area of the brain before. We don't know what it does. So we had the opportunity for the first time to go to this area of the brain and ask, what do the neurons here do? This is like a little bit like Christopher Columbus, arriving in America for the first time and meeting the people here and asking them, what do they do? So we were able to record with an electrode. This is the area, so this is the area we record from, and these are the neurons. This is called the subgenial cingulate gyrus. So we are able to record from the neurons in this area and ask, what are these neurons interested in? And we thought these neurons are probably interested in sad things because it lights up during sadness. So let's see. Are they really interested in sad things? So what we do is the patients are awake for the operation. We place a tiny electrode, a microelectrode, to record one neuron at a time in this area of the brain. And then we make the patient happy or sad or et cetera, and then we see what happens to the neurons. So this is how it's done. Patients are awake, and then we show them, for example, this picture. This is a disturbing picture. Or we show them a sad picture. Or we show them neutral. Or we show them happy, or we show them exhilarating. So we can show hundreds of pictures like this, and then we look at what does the neuron think of this? What does the neuron do while these pictures are being shown? And here, for example, you have this picture here. The neuron is firing at baseline at 4 to 6 hertz, and then we show this picture, and the neuron goes up to 14 hertz, which means that it increases activity, and then it goes back down when we turn it off. And when we do this type of analysis, we've discovered that the neurons in this area of the brain are very interested in disturbing and sad things, and they're not interested in happy or exhilarating things. So the neurons in this part of the brain, this is the sadness area of the brain and the disturbing area of the brain. And in people with depression, this area of the brain is on overdrive. The thermostat is set too high, and they're constantly in a state of disturbing and sadness. We think this is one of the causes of depression, because the neurons in this area are misbehaving, they're misfiring, and causing the symptoms. And so indeed, by going there and turning down these neurons, we think that we will be able to alleviate depression. We have also used this same target to treat anorexia. In anorexia, patients have comorbidities with major depression and OCD. And as you know, patients with anorexia have a refusal to gain weight, a fear of eating, and they have an image distortion problem. Even though they are quite thin, they see themselves as not thin at all. And we've treated 6 patients, which we published in The Lancet last year. We are now up to 15 patients. These are patients with severe anorexia. The mean duration of illness is 18 years. So patients who have been anorectic for many, many years. And now, after 1 year of treatment with DBS in this area, about half of them are back to normal weight. So about in half the patients, we are able to restore their weight. And they have not had normal weight for more than a decade and a half. So again, a very interesting target. And here we think that we are treating the depression, we're treating the OCD, and then this then in turn lets them enter into a program where they can go to an eating disorder program and restore their weight. So I've told you that we can use DBS to treat patients with movement disorders, with epilepsy, with mood disorders. Can we use DBS to make you smarter? So I think the answer is yes, right? But I'm not going to treat normal people. We are going to treat people with Alzheimer's, okay? So we started with a phase 1 trial. And the idea here is let's put electrodes in the circuits that control memory, and let's see if we can turbocharge the circuits of memory. Can we increase the activity, the efficacy, the efficiency of memory circuits in the brain? So this is Pape's circuit, and we place the electrodes to stimulate the fornix. For the residents in the room, so we have the outflow of the hippocampus through the fornix to the mammillary body, to the mammillothalamic tract, to the anterior nucleus of the thalamus, to the cingulate cortex, to the retrospinal cingulate, the entorhinal cortex, back to the hippocampus. So this is the memory circuit. And what we're going to do is place electrodes within this circuit to see if one could augment the activity in this circuit in patients with Alzheimer's disease. So this is what it looks like in an anatomical dissection. So the structure F is the fornix. So in humans, the fornix has 1.2 million axons. So there are more axons in the fornix than in the cortical spinal tract or in the optic tract. Okay, so the fornix is very important. There's a lot of real estate dedicated to memory in humans. Memory is important. So every neurosurgeon knows that we do not want to damage the fornix. If you damage the fornix, you get a permanent memory deficit. So we do not want to put the electrode in the fornix because that would damage the axons of the fornix. So instead, we place the electrode tangential, just touching the fornix. So we place the electrode in this orientation, like this, so that the electrode is just touching the fornix but not going into the fornix. And that looks something like this. So here you have the first patient in the world with Alzheimer's disease who was treated with DBS, and here you have the fornix fibers here behind, and the electrode is here. So the electrode have 4 contacts, and here running parallel you have the fornix. And on the stereotactic atlas map you see the electrode with the 4 contacts and the fornix, which is this structure here. So we are placing the electrode so that it's touching the fornix, and the idea is that the current will spread to the axons of the fornix, and we hope that we're able to activate the circuit, the memory circuit in the brain, by the focal application of electricity here at the level of the fornix. So this is what it looks like. So this is in the operating room, and I'll show you what this looks like. And we discovered something quite unexpected. When we turn this on in the operating room, and stimulate the fornix, some patients get vivid memories of when they were children. And here's an example. Déjà vu.
Once again, Lozano starts the electricity flowing into Moira's brain.
Moira, we're going to turn this machine on. You tell us if you feel anything, okay?
Okay.
5.
It looks like there's a group of people.
Right. There's some people?
I believe that they're people, but
Okay.
I can't say for sure.
Anybody you recognize?
Well, it's hard to tell.
Hard to tell.
Yeah.
Is this like a new scene or is it a scene from your past?
Oh, jeepers.
Is it something you've seen before or is it something brand new?
Maybe.
Are you feeling warm on
With a few more volts applied, remarkably, the details of the image get sharper.
We lived in this palatial place in Scotland where
From deep within Moira's brain, a childhood memory surfaces.
we just had all kinds of parkland to run around in
So
and everything.
that just came into your
Yeah,
mind now?
when I saw that, because the way that the picture is,
Right.
it's grouped.
Okay.
And I'm pretty sure it's a grouping of my sister and my brother.
So this is a lady who's 60 years old, and when we stimulated, she was thinking of being with her brother and sister in Scotland when she was 8 years old. And she had not thought of that for her entire life. And all of a sudden we turn on the electricity, stimulate the fornix, and this memory comes. So we see this in about 1/3 of patients, where we are able to get a very old memory, a déjà vu sensation, always autobiographical, when we stimulate the fornix. So what is happening when we're stimulating the fornix? So we're doing a technique called Loretta to look at what areas of the brain are activated. And as you know, we're stimulating here at the level of the fornix, but when we stimulate at the fornix, we're looking at the EEG and where the EEG changes. And after 50 milliseconds, we see that we stimulate here at the green artifact, and 50 milliseconds later, we see a power spectrum change in the EEG, and it's in the hippocampus. So by stimulating in the fornix, we're able to activate the hippocampus, which is about 10 centimeters away. If we wait longer, if we wait 250 milliseconds, then we get a transsynaptic spread of the activation, and we actually see the entire circuit lighting up. So you see here the cingulate gyrus, you see the entorhinal cortex, and the hippocampus. So by delivering electricity at the level of the fornix, we are able to activate the entire memory circuit of the brain. The more electricity we deliver, the more activation we get of this circuit. So we're getting both a local effect, stimulating the fornix, and also a transsynaptic remote effect. And it follows the natural anatomical pathways of the circuit that we're stimulating. We get very little spillover, or almost no spillover, for example, on the other side, and no spillover to outside the circuit. So when we stimulate within a circuit, the stimulation stays in that circuit with very little breakthrough to other circuits in the brain. So we're able to activate the circuit, so then the issue is what else is happening in the brain? So in our patients with Alzheimer's disease, one of the main problems is that parts of the brain shut down. So for example, this is a glucose scan. As you know, the brain uses glucose as its main fuel. Even though the brain only weighs 2% of the body, it uses 25% of the glucose. So the brain is a bit of a hog when it comes to glucose utilization. It turns out that the redness is the normal amount of glucose that the brain is using. As you progress to mild cognitive impairment, which is a precursor of Alzheimer's disease, you get a diminution in glucose utilization, specifically in the temporal and parietal lobe. And as you develop Alzheimer's disease, then there's a very marked decrease in the glucose utilization. So you have areas of the brain that are not so badly affected by the Alzheimer's. There's very little atrophy in the parietal lobe, for example, yet it is not using glucose. So it is as if these areas of the brain are shut down. It's as if there's a power failure in the brain. So this is a map of the United States at night, and this is an area of the United States where there's no electricity. So in Alzheimer's, it's like this, where there are areas of the brain, the parietal and temporal lobe in particular, where the lights are out. The brain is not using glucose, the brain is not working. And the question is, are the lights out forever, or can you turn them back on? can you restore the power to these areas of the brain. So we placed our electrodes in this circuit and we looked at glucose utilization before and after stimulation. And remember, these are patients who have the stimulators on 24 hours a day, and we looked before and after 1 year of continuous stimulation. So this is what they look like. At the beginning, before, this is 6 patients. This is the area of the brain that had a glucose utilization deficit. The areas in blue are areas where the glucose utilization is less than normal. The deficit is approximately 20% drop in glucose utilization in these brain areas. With progression of the illness, we expect these areas in blue to get bigger. More and more of the brain will stop using glucose until the entire brain stops using glucose. Instead, what we found is after 1 month or 1 year, we saw areas of increase in glucose utilization. So we saw increase in the temporal lobe here, in the parietal lobe here. So the message here is that, yes, the lights are out in Alzheimer's disease, but there is someone home, and it is possible to turn the lights partially back on. And this is very important because it means that in Alzheimer's disease, there may be a component that is reversible. We may be able to make areas of the brain function once again by stimulating them. And if these areas of the brain use glucose once again, it means that perhaps their functions can return. Finally, another problem that we have in Alzheimer's disease is that there is progressive atrophy, shrinkage of the brain. And this is seen most prominently in the hippocampus. So this is a picture of an Alzheimer's brain, and these pictures are taken every 3 years. Normal, mildly impaired, moderately impaired, severely impaired. And you see the hippocampus is disappearing. As the hippocampus atrophies, then you get a progressive worsening in your cognitive function. For example, when you have mild atrophy, you are forgetting where you put your keys. When you have moderate, you cannot find your way home. You get lost. When you have severe, you do not recognize your children. Right? So there's a very good correlation between the degree of atrophy and the cognitive function. So far, this progresses inexorably. There is nothing that we can do to stop this, to put the brakes on this process. So we wanted to know, what does deep brain stimulation do to brain atrophy? This is what we found. In the first 6 patients that we operated on, this is the 0 change. And we found patients 2, 3, 5, and 6, they had decreased brain volume, so they had progressive atrophy. So this patient, for example, 3%, this patient 14%. So on average, there was a loss of brain volume of 5 to 8%. This is normal for Alzheimer's disease. Every year, you will lose 5 to 8% of the volume, on average, of your hippocampus. This is normal, expected. What we found, to our complete surprise, is that in 2 patients, the brain did not atrophy. In 2 patients, the hippocampus got bigger. And this patient got bigger by 5%. This patient got bigger by 8%. This has never been seen in Alzheimer's disease, that the hippocampus can grow. So this is tremendously surprising to us. How could this happen, that the hippocampus is growing in Alzheimer's disease when the hippocampus is supposed to be shrinking? So we think that this is the first example that DBS can change the structure of the brain. Not just the activity of the brain, but also the structure of the brain. How could this be? How could DBS change the structure of the brain? So we've had to go to the animal models to investigate this. This is a hippocampus, the dentate gyrus of a mouse. And we know that the dentate cells, the granule cells of the dentate gyrus, can undergo neurogenesis, even in adult mammals, even in humans. There's constant birth of new cells in the dentate gyrus of the hippocampus in adult mammals. So this particular mouse is special because every time a new cell is born, it turns red. So this is a dye called cyan red, and it's off a nestin promoter. So what we did was we stimulated these animals in the fornix and then counted how many newborn cells are made in the dentate gyrus of the hippocampus. And what we discovered is that when we stimulate, we have 3 times more neurons born in these animals. So we can increase the birth of neurons by 3 times by applying deep brain stimulation in these animals. So we are using DBS to drive neurogenesis in these animals. Now, we do not know if this occurs in humans, but in animals we are able to make more neurons using electricity. Is it good to have more neurons in your brain? What if your hippocampus keeps on growing and growing? I mean, your head might explode eventually, right? So you don't want to do that. So you have to know, is this a good thing or not? So one of the things we did is, well, if you grow more neurons, is that good for you if you're a mouse? So we did memory testing on these animals, and we put them in a Morris water maze. This is a water tank, and the animals, on the fourth time that we test them, we take away the platform, and then the animals swim. And the animals remember where the platform was if they're stimulated much better because they spend much more time around the platform than the animals that are not stimulated. So the animals that receive stimulation have better memory. They remember where the platform was. So this is an example where we can show that stimulation actually increases neurons that are born, and also that this makes the animals smarter. They're able to remember the platform better. We are now doing experiments in animals that express APP, mutant APP for Alzheimer's. These animals get plaques, and also the Alzheimer's animals are better able to find their way in a maze as well. So we're able to improve the memory, not just in normal animals, but also in animals that are Alzheimer-carrying genes. Where we are now with this is we have just completed a double-blind trial with 42 patients with Alzheimer's disease. These are patients who have mild Alzheimer's disease. The patients receive the electrodes in the brain, and one half the patients, we turn on the electricity immediately for 1 year. The other half, they have the electrodes in, but we do not turn on the electricity for 1 year. They have the electrodes, no electricity for 1 year. After 1 year, everybody gets turned on. So we compare the patients that do not have stimulation. We expect their Alzheimer's to get worse after 1 year. To the patients that have stimulation, we hope that their Alzheimer's stays steady. So we will have the results in 1 year, and we will know, based on that, whether we can go to a phase 3 clinical trial, and then whether this can become a new therapy for patients with Alzheimer's disease. So that is where we are currently with our Alzheimer's research. The last thing I'm going to tell you is, let's forget about putting wires and drilling holes in the brain. What if we can do surgery less invasively without opening the head? And there's a technique called focused ultrasound that I'm going to tell you about. So this is using ultrasound beams through the skull to target very specific areas of the brain. And we're using this to treat patients with tremor, but you can use it to treat tumors, all kinds of things. So this is how this works. We have a helmet with 1,024 ultrasound transducers. And all of them are aimed to one spot in the brain like this. And this is very much like, with a magnifying glass burning a hole in a piece of paper. In the summer, you use a magnifying glass to burn a paper. Same idea. 1,024 beams through the skull, one spot. We're aiming it very precisely, 1 millimeter. We can hit 1 millimeter in the brain. This is the patient. So this is done as an outpatient procedure. The patient comes in, goes into this. We go into the MR. We're able to measure the temperature. What we're doing is we're heating the tissue in the brain. And we're able to see this in the MR in real time because we do MRs and we measure the temperature on the MR. And it looks like this. So here's the MR sequence. Here's the lesion that we're making. In this case, we're going up to 60 degrees, for example, in this spot. So we can aim for these neurons that are misbehaving. We can shoot the ultrasound at this site. The patient is awake. We can ask them what they're feeling. And we can make a lesion in the brain. In this case, a thalamotomy. You see we make a lesion here. This is immediately day 1, day 7, day 30, and day 90. So how does this work? So here's an example. This is a man who's an engineer, who's 60 years old. He comes in the morning, and he has tremor. He has essential tremor. He takes medicine, but they don't work. So this is what this looks like.
So we'll give him a 3 on the front of your nose.
So this is his normal tremors.
Okay, let's do it again.
He's going to try to drink a glass of water.
You're not going to be able to do it. Okay. Let's.
Trying to write his name. Okay. Okay, so very disabled. So he goes into the MR machine, we do the procedure.
After several hours, Tony is brought out for his post-procedure assessment, where the effect is crystal clear.
When's the last time you could do that?
More than 10 years ago.
He's not able to drink a glass of water for 10 years. So this is going to revolutionize neurosurgery. This is an outpatient procedure, no incisions. You come in, get the ultrasound, go home. We're going to use this for all kinds of things: epilepsy, tumors, pain. We can also use this technique to disrupt the blood-brain barrier, to get chemotherapy in, antibodies, etc. So I think this is really going to change neurosurgery. So in conclusion, I think it is clear that one can go anywhere in the brain now, safely. We can put electrodes in, we can use ultrasound, other things. We can reach anywhere in the brain where neurons are misbehaving, and we can change the activity of these neurons. When we change the activity of the neurons, we change the activity of the network, we change the behavioral output of the patient, whether this be a movement disorder, epilepsy, depression, anorexia, Alzheimer's. One can change the activity of the circuits in the brain. One can change human behavior. It's also clear that not only does DBS change the activity of the brain, but we can also change the structure of the brain. Electricity has trophic effects. We are able to grow neurons. This is tremendously exciting. If you can use electricity to repopulate neurons that are dead, you can reconstruct circuits. You can hopefully change the natural course of the illness. You can have a disease-modifying therapy, which so far does not exist for neurodegenerative diseases. To me, one of the most exciting things is that we are able to go to areas of the brain that no one has ever been before. We're able to have the brain reveal its secrets to us. This is really what's quite exciting. And one of the other exciting things is that you get to work with colleagues from many disciplines. You get to work with neurologists and psychiatrists and radiologists and scientists. And all together you have a different perspective. And together, working with a common vision, fantastic things are possible. So I think that working together, and in a center like yours in Porto Alegre, you need to do this. You need to all work together so that you can help many more patients. And I want to thank you so much for your kind invitation. Thank you.
Nós vamos ter algum tempo para fazer algumas perguntas, por favor. Microfone aqui.
Well, Matheus Roriz, I'm a professor of cognitive neurology. I could observe the beginning of the works of DBS at the University of Toronto when I am doing a postdoctoral fellow with Professor Maurice Friedman at Bakewest. So thank you for your presentation and congratulations for your work, Professor Lozano. Reading very carefully your paper published on the Archives of Neurology 2012, an open label trial, I wonder why your group, you personally, and your group have choose the fornix instead of the nucleus basalis of Maynard, that is more involved through the cholinergic hypothesis with the hippocampus, with the episodic memory. Thank you.
That is an excellent question. We are dealing with circuits in the brain. And even in Parkinson's, we have several different targets within the same circuit. In Alzheimer's, there will be more than one target because we could go to nucleus basalis, we could go to the fornix, anterior nucleus, entorhinal cortex, etc. The reason we chose the fornix is because the entire outflow of the hippocampus goes through the fornix, and also the fornix is a two-way street. The cholinergic septohippocampal system goes through the fornix. So we thought that it was the hot spot. It was the area where we could get the greatest effect. But this is just a hypothesis, of course, and it is quite possible that we could go elsewhere in the circuit, including nucleus basalis.
Professor, thanks for your speech. We have been using TDCS here and TMS, like non-invasive brain stimulation, different groups, psychiatry, neurology, and anesthesiology.
Right.
And my question is, don't you believe that could be complementary techniques because your technique, it stimulates some groups of neurons to inhibit or decrease the excitability. And the TDCS and TMS, which is electrically driven, it is also works at brain plasticity and release of some neurotransmitters.
Right.
So I was wondering if you have different mechanisms, you can combine both techniques, which is much more suitable in terms of practical use of the patients.
No, I think you're quite right. With these other non-invasive techniques, you are able to stimulate, non-invasively. There's a couple of differences. One is the targets are different because with the surface techniques, you stimulate mostly the surface areas of the brain, the cortex. You have less influence on the deep structures of the brain. So it's called deep brain stimulation versus, non-deep stimulation with TDCS. And so as you increase the current on the surface, then you have a bigger effect, but it diminishes the further away you go. And so the neuroanatomical substrates you can stimulate with DBS are different than with TDCS. The other difference is that with the non-invasive methods, you have to go to the clinic every day for 2 or 3 weeks. Whereas here, the patients have the stimulator in them and you turn it on. And so the compliance issue is easy, especially in psychiatric illness. Patients with depression, it's very difficult to get them to come every day to the clinic. But I think that there's some overlap, and I think that it would be much easier to have the treatment without drilling holes in the head. So I think we need to pursue this.
We work at the group in psychiatry, and we have some experience in OCD and depression. But one major issue is about schizophrenia and delusions.
Right.
Because hallucinations, auditory are more cortical, but delusions maybe would be confined more in thalamus or hippocampus. So do you have any idea what would be the target for stimulation, deep brain stimulation in schizophrenia?
So, schizophrenia is a complex disorder with positive and negative symptoms. For the positive symptoms, like the auditory hallucinations, I think maybe the auditory cortex. For the delusions, I'm not sure. I don't know if we have a very good map of where the delusions are coming from. On the other hand, for the negative symptoms, for catatonia and so on, we think that these are disorders of the frontal lobe. So we need to activate the frontal lobe. So I think that we are treating symptoms, not a disease, but rather symptoms. So if we dissect schizophrenia into what are the components, which is the most important one, where is that coming from in the brain, then we have a hypothesis that we can intervene at that site in the brain.
Professor, I'm not a neurosurgeon, I'm not a neurologist, I'm not a psychiatrist, I'm a sports cardiology. So I have 2 questions. First, when you is exposed to a presentation like this, the first thing I wonder is, one of these gizmos in my brain is fantastic. It's something unbelievable. But you talk about the good. I want to know about the bad. Sequels, side effects, and something like this.
The bad? Oh, there's no bad. So with these things, you can turn them up and down. So if you, for example, stimulate and something bad happens, with the stimulation you can turn it down or you can turn it off. So it's considered to be reversible, right? So you should not get a permanent problem from the stimulation. There is a 1% risk when you put the electrode in that you cause bleeding in the brain, and that can be bad. But that's rare, but it's a risk. So it is neurosurgery, right? But in terms of the stimulation effects, they are reversible because you can turn it off.
And
just a quick one. As a sports cardiologist, I have a look at their picture. The hippocampus been shrinked, and I was thinking, is there any cerebral exercise that you can put together with the procedure?
Yeah, so it turns out that if you exercise, if you run aerobic exercise, you can actually grow your hippocampus a little bit. There are some drugs also that can grow your hippocampus. So it is possible, but the amount of growth that we're seeing is greater than anything that's seen with anything else.
Just about a practical issue is about energy delivery, because I think that we developed very good techniques for intervention in the brain, but the old system of generating pulses is still primitive.
Yeah.
Because if you have an unreplaceable, but just have to replace, or now we have some to recharge.
Yes.
But the charge lasts very few days. People have to travel with the stimulator. And I think if you know about alternatives for energy delivery, like using light or using movement, like the old watches, in automatic watches that generates charge with the movement. If you put inside something like this, you have any idea of development on the energy delivery?
You know, the advances in batteries are not so exciting compared to other things, and you're quite right. Normally, every 4 or 5 years you need a new battery. Now there are rechargeable batteries. 1 hour per week, you plug yourself into the wall, and you get recharged. And they last for 25 years. There's some work in other forms of battery life. One of the most exciting things are biobatteries. So here you would take glucose from your blood or even adipose tissue to charge the battery. So this would charge the battery, and also you would lose weight. So it would have two functions, but this is still experimental. Even biobatteries are being considered, movement-related batteries, light. So all of these things are possible.
Just a quick comment, perhaps a provocation. When you see a presentation like yours, which is exciting, which is the future, that's right there, and from the standpoint of a university hospital, such ours, Toronto Hospital, what's going to be the future in neurosurgery? Because if you look at the components of a main neurosurgical group, you have the guys that do tumors, vascular aneurysms, spine, and now we see how is the field for functional surgery in the future. How you would combine the whole picture of neurosurgery in such a general hospital like such ours, in terms of space, human resource allocation, training, strategically in the next 5 to 10 years, is something that is going to be very provocative for us to discuss. How was this plan in Toronto 10 years ago? How did you guys do that? Tell us, because this is going to be complicated from now on to hold on these guys, you know?
So, you know, I showed you on the graph, functional neurosurgery went from nothing 20 years ago to very high volume. And the important thing is multidisciplinary teams. So we have to be dedicated to patients and diseases rather than techniques. So we are interested in schizophrenia, depression, Alzheimer's. And as part of the team, you need neurologists, psychiatrists, psychologists, neurosurgeons. And this is how we work. So we have an Alzheimer's team, a depression team, movement disorder team. And we meet and we conference all the patients, and we make decisions together. This patient is a good candidate for surgery, this patient is not. So I think that we are going to see a blurring of distinctions between neurology and psychiatry. We're going to see a blurring, you know, the same has happened in other things in neurosurgery where now radiologists are treating aneurysms, for example. So this is the trend in medicine where the disciplines are blurring, the walls are falling, and now we're applying everything possible to treat the patient. But so the secret is multidisciplinary teams, I think.
Well, regarding the Alzheimer's team, we are already doing this hospital. we are quantifying beta amyloid protein on the CS fluid and tau protein.
Yes.
So you are conducting a study with mild cognitive impairment of the amylase type. So my question to you, Professor Lozano, is that are you quantifying beta amyloid and tau on CSF fluid? Because otherwise, since you are allocating initial Alzheimer's disease, probable Alzheimer's disease, and often we have depression together, right. Even though you can't do a diagnosis of the depression, sometimes like you have some cognitive complications of mild symptoms. So are you, since we cannot do a biopsy to quantificate, so are you doing a PET or are doing a CSF fluid quantification?
So in our first trial, we did not do that. In our second trial, we will. So we will do beta amyloid imaging and also lumbar punctures for longitudinal assays of tau and neurofibrillary tangles as well, and A-beta as well, right?
Eu quero agradecer e antes de concluir, acho que a mensagem mais importante dessa conferência para aqueles, especialmente para os mais jovens, é que lembrem-se que isto é uma técnica em desenvolvimento, apesar de alguns profissionais como o professor Lozano ter uma grande experiência, mas mais do que tudo, em função de uma das perguntas feitas, que é uma técnica que é regulável e, nesse sentido, o para-efeito pode ser imediatamente tratado com a regulação para menos do estimulador. Então, isso não é uma técnica definitiva. E o grande benefício dessa técnica é exatamente permitir a modulação do tratamento às custas da modulação do aparelho. Então, não é uma técnica destrutiva, mas sim modulativa.
Mais alguma pergunta ou comentário? I really would like to thank you, Dr. Lozano, for your presentation. You give us not only your experience in your field, especially related to functional disease in the brain, but especially you said and give us the information that we have to work in a multidisciplinary team. I'm not a neurologist, as you know, and I'm not a psychiatry also, but I'm very curious about my brain, the brain of everybody else. And so I think your area of activity is very, very important for all of us. Thank you very much for your presence and for your kindly presentation. Muito obrigado a todos. Até a próxima semana.